I would like to present our experience with SLEEVE-DOR technique, sleeve gastrectomy with anterior door fundoplication for obesity. We have the first series in Germany, and I think this is a good technique that we can apply for many patients with a problem of the obesity. So here are my disclosures. None of them are related to this presentation. And my second disclosure slide is about that sleeve gastrectomy should not be indicated in patients with known symptomatic gastroesophageal reflux. We can avoid many problems by surely better indicate a tailored approach for the obesity. So the problem that we have at the present is that we have growing incidence of de novo gastroesophageal reflux and Barrett in post-sleeve gastrectomy population. So these patients are showing this many years after the procedure. They were not symptomatic before, and the proposition that we can make a prophylaxis for these patients doing a routine performance of an anterior 180 degrees fundoplication as a SLEEVE-DOR procedure. So the problem with the reflux is that many patients have a de novo reflux. So 5 to 10% conversion to Roux-en-Y gastric bypass due to reflux, and de novo GERD in 31% in many studies here. So in sleeve gastrectomy and only 10% in gastric bypass. So we show also that we can also see that Barrett is discovered in almost 18% of the patients in other studies. We have here a study from Antonio Iannelli, 5 years systematic endoscopy after the sleeve gastrectomy for non-symptomatic patients. So, and then they showed in 6 years, 6 to 5.5 years, Barrett in 18%, 18.8%. So that it is very alarming, these statistics. So we know also patients with esophageal carcinoma in Germany after sleeve gastrectomy. So the physiopathology, this nice study from Silvana Peretta shown us that the structure, the anatomy is disrupted after the sleeve gastrectomy, that we have another angle of the Eaes angle. So, and then these patients have probably this reflux added also with a high pressure system of the sleeve. So what we can do about this? So many propositions were shown in the literature in the growing incidence from the Nissen sleeve and Rossetti sleeve. We don't think this is a solution. They have a good relief for the reflux, but they shown as an alarming incidence of 6.4% of necrosis of the flap and also reoperations. So here in this casuistic von Omi, so with 14 from 200 patients were reoperated. So, and also with the problem with the weight regain, because we are lefting a very big stomach flap and doing showing also weight regain in some casuistics. So André Teixeira was the first to publish this fabulous technique. This is the SLEEVE-DOR for patients with reflux. So they had 31 patients and all with symptomatic GERD, and the GERD score dropped after the SLEEVE-DOR operation from 17.9 to 4.1, and they have only one leak in this series, and they had a short follow-up, but very good, nice results for these patients. So other casuistic from the Eugenio from Italy, they did also for patients with symptomatic GERD, the SLEEVE-DOR technique, and they allowed the MISTA score much better after this operation. That is then no need to convert it to Roux-en-Y gastric bypass because of reflux. We have to see here what we are doing. We left in this technique from SLEEVE-DOR, our series, we're doing left a small ear on the on the fundus that is well vascularized, and then we add only one suture with the V-lock to the right crura, and this is a very easy technique that allows us to do an anterior fundoplication for patients with no symptomatic GERD before of the operation. So this is for the two-step sleeve gastrectomy, that the second step will be probably a SLEEVE-DOR for the super obese patients. And here we see that this technique is very easily performed with only one suture with minimal dissection of the structures and preserving all the anatomical structures. So we perform this in the, not between the legs. All of our bariatric surgery is from the side of the patient. So we move the camera then to the left side of the patient. So we have the surgeon at one side and the camera at the other side, which facilitates the changes of the patient from one patient to another. So our results in our first series, we have 69 patients. We have corrected hiatal hernia in 7 patients. We have, after this procedure in 3 or 6 months, we have 3 conversions to Roux-en-Y gastric bypass, and reflux was relieved in all other patients, 66 patients with no medication after procedure. So excess weight loss was good in 50.1% in 6 months, and we have no leaks. We have no postoperative bleeding, 2 dysphagia of this patient, and 1 reoperation for a necrosis of the small part of the colon on 9th postoperative day with a local peritonitis, went also good with laparoscopy. So if we see that we did here the half of the patients by robotic assisted with Da Vinci, and 35 patients laparoscopically, we see that the operating time is faster for the Da Vinci operation, surprisingly, but most of the SLEEVE-DOR operation were doing by residents laparoscopically until now, yet not robotically. That's why, because the operative time and operative stay. So we use no drains for this patient. We give clear fluids 1 hour after surgery. We do no studies radiologic for this patient, early mobilization, fast track surgery and discharge 48 hours postoperative. Not all Barrett are really Barrett, and so of these patients have a tubularized cardiac segment that was shown very well by Wendy Brown last month in a publication, Annals of Surgery, that showed that this is a maybe misunderstanding from the endoscopies and interpreting the Barrett. Not all Barrett is a real Barrett. Let's see what happens later, but here we see real Barretts with insular invasion and typical aspects, and here we see that what happened in many sleeve gastrectomy is only a tubularized mucosa or the stomach going into the thorax, and not showing that the statistic for Barrett maybe is not so high. So we use this as second step for super obese patients, and we think that if we do the SLEEVE-DOR, we can do the SADI as a second, because then we don't have the reflux for these patients. Conclusion is that the novel gastroesophageal reflux and Barrett is a growing issue in the bariatric population after the sleeve. A new simple procedure as a SLEEVE-DOR can solve probably this problem. Let's see what happened in 5 years. 5-year endoscopic surveillance is needed to know the real benefit of the technique. Thank you very much.